All right, it's 6:30. I'm going to call a meeting to order of the Nursing Center Committee. 1.0 prayer, Mr. Whalen.
Let's pray.
Oh, Lord God Almighty, thank you for the opportunity to once again come before you and serve the people of this county in this fashion as the Nursing Center Committee meets. I pray that you help us make good, wise decisions, that we communicate effectively and sufficiently to work out anything that we work out tonight. And I pray that we do it all to your glory. In Jesus' name, amen.
All right, 3.0 approval of tonight's agenda. Do I have a motion to approve?
So moved.
By Mr. Whalen. Do I have a second?
Second.
By Mr. Bush. Any discussion? Seeing none, all those in favor say aye.
Aye.
Motion carries. 4.0 review and approval of meeting minutes from January 9th, 2025. Do I have a motion to approve?
So moved.
By Mr. Whalen. Do I have a second?
Second.
By Mr. Bush. Any discussion? Seeing none, all those in favor say aye.
Aye.
Opposed? Motion carries. 5.0 approval of claims totaling in the amount of cash requirements and manuals of $403,952.63. Do I have a motion to approve?
Motion to approve.
By Mr. Hadley. Do I have a second?
I'll second.
By Mr. Whalen. Any discussion? Seeing none, all those in favor say aye.
Aye.
Opposed? Motion carries. 6.0 public comment. Nope. All right, moving on. 7.0 reports to committee. 7.1, Mr. Administrator, you have the floor.
Okay, I'm going to start with the normal format that I've used in the past as far as information I normally relay to this committee, and then cover a few additional areas as well. You guys have seen me do previously, this report obviously is for the month of January as far as a reporting period. Census, when I created this agenda and submitted it for to go into the committee's packet, census as of that day was 43. Looking at a bit of historical data, as I try to include as well, the average monthly census, and again, that's just the average monthly census for January, was a high point since I've been on board, since I took over in August. With a census of 39, the average monthly census for January was 47. And we were approaching 50, actually, until things dropped off a little bit more recently.
You said it went from 39 to 47?
39 to 47. January's average monthly census is was 47. Today being February 13th. So, average monthly census for December was 44. November was 43, and the same thing for October. So we've been kind of on an upward trend. Just looking at our referral processes, even just in terms of the time it takes to process a referral, to look at our clinical capabilities as far as our ability to provide sufficient care for anybody that we would admit, and then also for our ability to, or for the resident or the patient's ability to have a financial payer source to cover their stay. I'll also take a minute to introduce, I asked for tonight, at least out of any night, as far as our business office manager, Jennifer Alanese, who's here with me tonight, to kind of join us. Just considering we've been in a little bit of transition anyway, so I figured she could help maybe make a few points with me tonight as well. As you guys have seen me do before, or as the members have seen me do before, as far as the breakdown of census, as of the 43 that I had listed there, the Medicare A, Medicare A is being the short-term rehab to home on average. Traditional recipients, those that have traditional Medicare, we have 3 of those, which I've also started to add from month to month. If it's been an increase or a decrease, depending on what type of payer source that it is, that's up by 2 from the previous month as far as traditional Medicare. Medicare replacement plans, those people that come in and have insurance companies that dictate how they use their Medicare short-term rehab to home benefits. We had 1, which was a decrease of 3. So that fluctuates again from month to month. Those that have an insurance company that manage their long-term Medicaid plans, there's 22. That number hasn't shifted too much. That was a drop by 1. Those that have, they're under receiving hospice care by a hospice agency that also have Medicaid to cover as their payer source for room and board. There were none for January in this case, which was a drop by 1. Those Medicaid pending, so just so the committee knows, just as a reminder, those individuals that come in that maybe don't have a payer source or that can come in under their skilled short-term benefits, but then need to apply for Medicaid. for a long-term stay. So Jennifer can speak to that at any point, just in general in terms of us getting them signed up for Medicaid. That's just as far as that process.
If I may, just to be clear, in each of those cases, the expectation is that they will be approved for Medicaid, correct?
That is the expectation.
Yeah.
You can speak to that if you want to.
Yes, no, that's correct. It is. Mhm.
Just want to make sure everybody, I've been through that process, like, I get it.
It's a process.
Yes.
I got a
Sure.
question. The census.
Yes, sir.
Do we have a waiting list by any chance?
No, not yet. Being that the facility's bed capacity is 150, and the census has fluctuated, from the upper 30s now into the 40s, we still have beds available, at this point.
Well, I received a call that said there's a waiting list for people to get in, some to do with a heating problem at one of the wings.
So I was contacted about that as well from
Okay.
different members of the county board. I was also questioned by the county administration, and I've explained that situation, but I was going to go into detail on that tonight as well.
Oh, okay, that's fine.
During-
But
during
we can have 10 people tomorrow come in and we have no problem.
Well, I'll go into detail about
Okay.
that in this section. So
Okay.
I'm going to
thank you.
include that in my maintenance report in this case,
Okay,
along with what the maintenance director had included. So we will not miss that. We will discuss.
okay, thank you.
Let's see. Again, talking about Medicaid pending residents, those that have traditional Medicaid benefits, about 8 of those people, no change there. Private pay, those that are just traditional self-pay or private pay, we had none for the month of January, which was a drop by 2. And then private pay, again, those receiving hospice care but paying privately for their room and board, we had 2 of those. So no change in there, creating the 43 in this case. The total admissions for the month of December, for the month of January, right? I didn't change the month on that, was 9, which was an increase by 1, which was is a significant increase. And the most of what we admit are short-term people. Those are the vast majority of the referrals that we do get, are people coming in for rehab to home. Which, if they don't go home, that helps the long-term census, which we're working on building as well. But, the goal is to rehab to home, to go home. So that's always the intention for those who come in and use their short-term benefits, their Medicare benefits, for that purpose. So just to give a breakdown of the census for the month of January in this case. From a departmental overview, which is kind of how I started to break this down a little bit. As requested by the committee chair, the activity director, Brenda Rothschild, has included an activity calendar in the committee packet, I think, for now February, or for, I think maybe I meant to put February maybe on that one. But as far as the activity programs that are put together for the residents to keep them engaged, both now, the terminology I've been using is what I call the main building, which is outside of the Alzheimer's and dementia care area, because they have their own activity calendars put together to keep them active and engaged in that area as well. No significant changes. Again, just creating new programming for those residents now that we're actually using that area as a care area for those that have Alzheimer's and dementia diagnosis. From an accounts payable standpoint, Jennifer can speak to this a little bit, actually probably entirely to it, but when I first came on board as business office manager, she obviously was overseeing and still oversees accounts payable for the facility, but being assisted now by Carolyn Burke, who is our accounts payable, part-time accounts payable specialist. As far as claims that come into the building, I think you can speak to that whatever you want to.
She's been doing a fabulous job. I know that everything was done and sent off for February's claims, and then we saw the email today going out that from Laura that March can start with it. So as soon as she gets back, she'll be starting on that and working on March's. So,
and just so there's no question ever, hopefully, as invoices are received, they are processed, and they are processed through the county system CIC. And they are, ultimately signed off by this committee, the county board, and sent over to the county treasurer's office for processing. So anything that we receive, we do process and forward on. So just so there's no question as to that.
yeah.
As it relates to that, as far as accounts payable items, again, as was reported by even at this point, it's actually even from the county treasurer, as far as outstanding items, outstanding payables for claims. I mean, that is still the case. Those are amounts that still do exist. And correct me if I'm wrong, Jennifer, but I mean, at this point, even since I've been on board, it's, paying those additional claims outside of what I would call current claims within our ability to do so. As far as revenue comes in, we make the efforts to pay those outstanding claims as far as what they are, as far as our ability to do so. that's what I would say about that, as far as the claims that are still, I get officially outstanding at this point. So that's what I would say about that. I think that's all I had as far as those items in this case. I will make a note as far as the therapy invoice.
Let's wait until we get into closed session
Okay.
about that, if you don't mind.
All right. I'll continue on. Jeannie Cross, who's our admissions and marketing director, did, I do believe, forward over for the committee's review her referral list, referral log, as far as referrals that we receive for the facility. Jeannie, I feel, as I've said previously, I think made a great contribution to the facility as far as her role in the facility of overseeing admissions and then processing referrals, as far as her relationship with the various referral sources, both here in Stephenson County and beyond. I've already reported on our census data as far as changes from month to month, so that's a direct reflection of that as far as what that is. The assessments and reimbursement, as far as from that standpoint, the MDS nurse, Alex Guilfoyle, who's been with the facility for quite some time, she's a registered nurse. She oversees all the quarterly comprehensive assessments that are carried out on all the residents, working with the individual department heads, making sure that we capture every item, across all of our T's and dot all of our I's, so that any reimbursement that is due to the facility based on our level of care that we're providing is ultimately submitted to the facility, is provided in that way. So we continue to work with her in that process as well. As far as the business office, we happen to have our business office manager with us tonight. And I begged her to come tonight, so just for tonight anyway. She obviously had submitted a report to the committee as well. I didn't know if there were any items of note or any highlights you wanted to kind of throw out there at this point.
Unless anybody has any questions on any of them, I mean, it's pretty.
We are going to come back to Jennifer as far as our new processes with Matrix Care and Quality Healthcare Resources. So we're going to double back on that as well.
I did change the information that I submitted last month based off of Quappy, so I just went ahead and did it off of there. So other than that, if anybody has any questions on any of them, but it's pretty basic.
Actually, you know what? We will actually look at that right now as far as in our business office. In some of the material, the paper material I passed out, that one on the far left for you, Georgia, it says approved admissions on it. That's kind of a big staple. That one. If you go to the very last page of that one. So suffice it to say, and just to kind of give you some dates involved. I'm sorry.
No, I didn't. I'm sorry.
To give you some dates involved at this point, just kind of show you where we've been and where we're at this point. In January, in this case, on Tuesday, January 28th, which was about 2 weeks ago, we had our kickoff call with Quality Healthcare Resources, which, again, just to restate for the record, is the company that's been subcontracted under Matrix Care through our agreement with Matrix Care to assist with billing and collections. So with that meeting, Jennifer, as the business office manager, has been dubbed as far as their primary point of contact with the building. So as far as what you see on that last sheet there, those are items that we've discussed with the Quality Healthcare Resources team. I don't know if you wanted to go through any of those in particular, Jennifer, as far as things that maybe we've discussed or that we're working with them on, or things that maybe we've already accomplished with them.
A lot of it was items that we had been working on in the facility. They did send over their format. So and I've worked with them to either keep the format that we have been using or switch over to theirs. The new referral process, screening all for referrals. We do all of those items already and had been. Completing the NRI packet, that's the business office, Jeannie, and she is sending those out to the people that she has contact with. The non-NACs, that's would be social services, which is Nancy, delivering and completing those. And then just reviewing, they're going to be reviewing all of the admissions and the payer sources. Excuse me, completing the Medicaid questionnaire. So we've been working on those items as well. Medicaid applications for anyone that's coming in, and the recertifications. And then we're going to set up the weekly tracking meeting. And then I know we have one set up tomorrow, also actually tomorrow morning. And then they're doing, the deposits. So posting after I do the deposit, I send it to them. They're going to be posting those items to the correct payer and the correct resident. collecting the Medicaid pending residents. So, I mean, a lot of it we have been doing already. So I'm just kind of moving forward with that and working with them closely.
Excuse me. They have an entire team devoted to 2 different areas. So a lady by the name of Yehudis, I'm sorry, not you, well, Yehudis Geffner is part of it, but also you've been dealing mostly with Rachel
Yes.
Rochel or Rachel Nyman or Bahensky with Quality Healthcare Resources as far as everything that we've been setting them up with at this point so they can get access to the systems that they need to be able to access to be able to do proper billing. Just to answer, I think probably one of the main questions I think that this committee probably had. They are already seeing 2 billing for the month of January. So that's something
Yes.
they've already long since jumped on.
Yes.
So that I don't really have any concerns with. Remember that, as I had mentioned to the county administrator, that now that we're in February, as it was, we would still be doing reporting on December, which the previous provider was in place at that time for December. Going into March, then we will do financial reporting for the month of January, which the new provider, as far as Quality Healthcare Resources, Matrix Care, had now been overseen. So as far as what I would call the more normal billing starting for the month of January onward, is that area of focus. And then I also included a supplemental, this one here, the AR cleanup packet. This is something that Jennifer and I have gone through with them more recently. Just various pieces of information there, kind of, and it actually does specifically note it there as far as the, I guess it'd be the title page and then 2 pages after that. The start date listed there is as soon as possible. Dates of service for the AR cleanup listed as December of last year and prior. So just to note that. And they will be going, and again, just noting they're all payers except for private pay, is what was noted here. So we're talking about all the Medicare claims, both traditional and managed. We're talking about Medicaid plans.
Have they seen this?
Yes, because they have access to our aging.
Okay.
Yeah, they have access to all the primary parts of Matrix Care, including more recently the claims management area.
Yes.
So yes, they have seen all of that. So they have the work cut out for them. But I have very high faith, and my familiarity with this organization, they will be able to dig into everything that they said that they will be able to dig into as far as every single claim that's still outstanding at this point, and make a determination for the county as to what is they view as collectible and not collectible. And as I think the county board as a whole had heard at I want to say I guess it'd be the January meeting of the county board, that there are timely filing deadlines with certain claims. So they will be going through all of that, and again, just making that determination for the county as a whole. My expectation, just for what it's worth, is that they would give that kind of a snapshot expectation as a whole for everything that is that. Now, it will take them a little bit of time to go through every single claim, but they'll be working through that, I believe, fairly quickly. I was going to say, noting there as well, those items that are under, so going December back a year, listed there is 15% of net collections as far as what, they would obviously be able to take on their end. And then those items that are older than that, basically, as far as a 30% amount there for net collections. So, but again, this is a very professional organization. As far as their own ability, speaking for they themselves, going back and going through all those details. And we will be able to get from them an idea as far as when they would complete that process. But again, we're only 2 weeks out. So they're still getting their hands dirty at this point, going through that process. As far as AR cleanup, the normal billing and collections, again, looking at now January, they've already, as I said, jumped on that. So they are in the process of doing that already. So, and the proof will be in the pudding as far as the aging that you guys see, as far as, even for the month of January going forward, as you see amounts listed there for every payer source for those, again, in this case, more recent time frame. So even just the month of January going forward. So that is my expectation, is we would see those amounts not, show as collected, basically. And if not, then we'd be able to, between the business office manager, Jennifer, and myself, we will have monthly meetings with them during the day. But I will bring that information to this committee for the committee's review, because the difference here is compared to the previous provider in terms of distance, is that these people are a little bit farther away. Matrix Care is based in Minnesota, and Quality Healthcare Resources is based in New Jersey. So as far as them being able to come here physically in the evening on the second Thursday of the month might prove a little bit difficult. I asked the committee chair as far as maybe having them remote in, maybe, I don't know. But that information will still be provided on a month-to-month basis, which is what I'm used to. I think Jennifer can speak to that as well, as far as, going through any outstanding accounts that they view as more complicated, as far as if we're waiting on certain paperwork, as far as their Medicaid coverage, if we're talking about amounts related to patient liability or
Yes.
patient portion, as far as things that we're not getting paid for by the family or by the resident. We'll have those details on a month-to-month basis and be able to show those amounts collected in the end. But again, I think I said the first priority was just to get January billed as far as the normal billing and collections processes, which again, Jennifer's been working with them pretty heavily and closely as far as those processes. Getting them set up to be access all the systems they need to be able to do that. Not just in Matrix Care, but as far as government online systems and such. So we will try now to determine as far as what they feel will be, and what soon point they feel they'll be able to look over all the accounts, all the claims that are still outstanding that are, from whatever point in the past as a whole. So we can kind of get an idea from them as a whole as far as what they feel will be collectible or not in this case. So that is my expectation at this point as far as the work that they're doing now.
Quick one. Jennifer, if I could ask you, I think we get a sense from where Marcos stands with the changeover. What's been your experience so far? Are you feeling better about the things going forward than where we were a month or two ago? Or
I mean, it's still early on, obviously, but I think it's been going great. I think it's the transition of everything, but they have been extremely eager about getting started. And so we were just trying to get access to everything for them, which is, took a little bit of time also, but I think it's going to be great. I think that it's the perfect fit as far as with us working with Matrix already and using their software. And then also with the collecting company, working with them as well. I think it's going to be a very good transition. It's just going to be time just to get everything kind of smoothed out, but I think it'll be good.
Good. Thank you.
Yes.
I will say, and there is I would say more of a single focus as far as, this provider working with in terms of, solely billing and collections, and that being their focus and that being their area of specialization, just that, and nothing else. I mean, in this case, so. That just being a uniqueness as far as their organizations.
Thank you.
But again, as far as from a billing and collection standpoint, that is where I would say we stand at this point. In terms of their efforts, the steps that they've taken at this point, I feel that we are on track as far as being able to operate going forward. Them having, like I said, already jumped on billing and collections for January, and then now also their AR cleanup team working now going backwards. And again, trying to get an idea now at this point as far as when they feel that effort will be completed. Again, them having to go through every single account and claim that still is outstanding at this point and determine what's collectible and what's not. So that's my view of it at this point. So go back to my report here. Excuse me. From a dietary standpoint, no significant changes there. I will note a few items within the more recent annual survey that just happened to take place prior to this month's committee meeting. They ended up coming in on Monday, actually, I guess it was just last week. Yeah, Sunday. They came in on a Sunday, no less. On Sunday, the 2nd of this month, stayed through last Tuesday, the 4th. So a few dietary items there that I will bring up during the course of this meeting. From an environmental standpoint, no items out of note there, with the exception of noting not, I would say, an immediate need. This is something that I would say maybe carried through from the previous fiscal year now into this one, as far as the potential of either a new replacement washer or paying the money to continue to prop up a machine that's going to be kind of a money pit. The facility has 3 commercial washers. When I first came on board, they were only using 2 of them. One hadn't worked for I don't know what amount of time. The second one started to become more problematic, and so we were left with 1 basically for the most part at this point. The facility, to note, also has 3 commercial washers, all of which operate at this point. But again, looking at the possibility again of even putting more money even into this now second washer that we've been using, or just paying the outright cost to replace it. So I'm not prepared to take that into more detail, at least at this month. Probably next month, I will take that further at the committee's discretion. So just to note that as well. From an HR standpoint,
I'm gonna quit.
Yes, Mr. Hadley.
Could you price that for us, a rough price of that?
I have actually already done that. So I will prepare that it's just because of the prioritization of everything as of late. I'll bring that to the next committee meeting, but that's going to look, that cost for replacing that, and those are unfortunately not very cheap. That would come in around $15,000 to replace a new washer, commercial washer in this case. The cost to repair it would be at least not that far from there. We'll put it that way. Somewhere between 10 to 12,000. So just throwing that out there, at least to put on the committee's radar, I guess, at this point. So just something to think about as far as that. From an HR standpoint, Kendra Martinez, our HR director, did submit her report for the month as well. As far as I usually report on terminations and hires, those numbers have remained, I would say, overall stable for the most part. I just as to put on the committee's radar as well, and I will note that I've made commentary in the past as to maybe certain items that were discussed with this committee in the past in terms of wages for staff. Obviously, with the current wage structure, I wasn't on board when that first went into place, but I do have some concerns. I will say as far as our ability to attract applicants, both licensed nurses and certified nursing assistants. And I, having worked at another county home, previously, I understand it's an apples and oranges kind of situation as far as, for-profit nursing homes and government-run facilities. And trust me, I totally get that. But I would also make the case that we might have to look into the possibility of maybe some sort of restructuring. Because the flow of applicants that we've been receiving into the facility, unfortunately, has not really been what it's needed to be, even in the time that I've been on board, and the amount of usage of contracted labor, licensed nurses and certified nursing assistants, has been very high. And the unfortunate part of using contracted staff is that the cost is usually far above and beyond what you would normally pay a normal employee. So we're already paying costs greater than what we should be to begin with by a good amount. So I just wanted to put that on the committee's radar at this point as far as that situation, as far as where we stand with that at this point, and looking at possibilities going forward with regard to that.
I got a question on that.
Sure.
Are you aware of the state program that they have for CNAs?
So from what I've been told, Mr. Hadley, I believe that topic may have come up in the past.
Yes, correct.
Maybe prior to my arrival. I am familiar with it from other organizations that I've worked with. That is something that I would probably maybe try to reapproach, speaking for myself, just to perhaps make an attempt to try to provide that benefit to those staff at the very least. I will tell the committee that the new union representative Cody Dorns has approached me about that, and he has talked to me about that. So just to make a note as far as what that is. But again, that's simply just a discussion at this point. So
I believe at one time we looked into it, and you might want to look into it again. I think it's on the state website. I don't know how many nursing homes are doing it in this region, So I can't remember who's doing it, but I believe we were told that there was a few that were doing it in the region. So maybe that's something. When you approach us again on that, it's well, so-and-so does it here, so-and-so does it there too, so.
I can't speak to the exact number, but I do know that other for-profit facilities here in Stephenson County make use of that program.
Okay.
According to what I was told, the county nursing facility in Winnebago County also utilizes it there. So, for what that is. But that's what I know at this point. But again, the point of this was just to bring it to the committee's radar. Just that I do have concerns in that way. I'll put it that way in terms of the flow of applicants that we've had at this point. So I will say that.
Thank you.
From a medical record standpoint, as far as our medical records coordinator, we've been making heavy use of her, Ms. Joy Sunga, as far as medical records requests that have come in for auditing purposes. And we're responding to those as they come in because we've been subject, not just our facility, but every facility from the point of view of the federal government has been submitting audits as far as documentation that we've completed that we have to submit to them per their requirements to make sure that we've crossed every T and dotted every I's. Otherwise, we'll be subject to recoupment of payments from either the Medicare or Medicaid program. So we continue to jump through those hoops, as it were, as far as those are concerned. Again, as far as the nursing department, Annette Williams is our Director of Nursing. In this case, no significant changes there. I've already discussed as far as our staffing situation and her utilization of contracted staff, both licensed nurses and certified nursing assistants. I've also, unfortunately, and again, forgive me for killing some trees tonight, but as far as our annual survey, I did, and I will not go through this in detail, but I will at least specifically know what we were cited with in the end. The health survey is one of 34 pages. It's the one that starts with the very first deficiency on the left that it's cited as F602, which you can see the S and S means scope and severity of a D. So I did include in the committee's packet the scope and severity scale. Going up and down refers to the, that's on the electronic, yeah, that one, that's in the electronic committee packet. Up and down refers to the severity. So as far as if any harm, if any, actually occurred to a resident or residents. And going left to right refers to how widespread of an issue it is. So a D in this case, being in the lower left, refers to being, whatever the issue might be, being a low severity, and more of an isolated issue. So the first one there, F602, and I also just for the committee's reference included a breakdown of each individual tag that we can be cited for, which there's probably over 300 of them that any facility can be cited for. F602 refers to residents being free of misappropriation and exploitation. The main part of having read these for years, the one that the paragraph I always go to is where probably the second one down beneath that, where it says based on interview and record review, the facility failed to do whatever. And so in this case, the state has made the case that the surveyors that inspected made the case that the facility failed to ensure misappropriation of resident property did not occur for 2 of 4 residents. Long story short, there was an investigation carried out, which does occur from time to time, as it relates to missing medication for 2 residents in this case. And the state was aware of that fact because we actually reported one of them to them. The other one was a fentanyl patch, which was being used by a resident that showed up missing. But that could have just fallen off. But the state viewed that as a concern as it relates to being free from misappropriation and or exploitation. So we were cited for a level D deficiency for that. Going down to page 5, F604 is in alignment with the same issue. There's different tags that can be cited for a similar issue. That one being listed as the right to be free from, I stand corrected. That one is slightly different. That one is the right to be free from physical restraints. That is an E, which means that it's a low severity issue, but it's more of a pattern. What they viewed as more of a pattern in this case. Long story short, they viewed our use of bed bolsters, which are kind of round cylindrical devices that you put at the edge of a bed to keep a resident from hopefully not falling out of bed. They view those as they view those as restraints now. So, which is a change. I'm not used to that because I've used those for years in facilities. So, the state does view those as restraints. That's on par with in recent years the discontinuation of the use of things like bed rails. Also, certain cushions that make it difficult for a resident to get out of their wheelchair if they're at risk for falling, or things like that. So there have been changes over the years as it relates to things like that. Even now in terms of softer bed bolsters, as far as what that is. F607 on page 10 refers to, and this one is also connected to the first one as well. 607 refers to developing and implementing abuse and neglect policies. That one was also a D, which was low severity, isolated scope. And long story short, in this case, the facility, see how they wrote it here. We failed to ensure that our abuse policy was implemented. So long story short, the concern of the resident that had a missing fentanyl patch, the nurse did not report it as she should have, as far as just missing medication. And so the state had a concern with that, so they cited us for that in this case, because the nurse did not follow procedure. On the next page, F609, reporting of alleged violations. That was also low scope and severity. That was along the same lines. That was because of the fact that, again, with her not following procedure, which was its own issue, that was also not reported. The missing medication was not reported. So she did not follow procedure in that way. And so that was shown to be a concern on the part of the state. So then we were cited for that. On page 15, ADL care provided for dependent residents, F677. also low scope and severity. In this case, this had to do with a resident that was not provided appropriate incontinence care. In this case, you'll notice a lot of these are just for one resident out of a certain sample, 1 of 13 in this case. So unfortunately, that is how it is looked at sometimes, even just for one resident. And as I said, in this case, for proper incontinence care having not been provided to a resident. F684, the next page, quality of care, that was also low scope and severity. This is a resident who was at risk for skin breakdown, who required the use of a protective arm sleeve to be put on her arms to protect if she were to come into contact with something that could tear her skin. When the surveyors reviewed, the resident did not have them on. But it was also noted that the resident doesn't like to keep them on, so that can be problematic as well.
That is my grandma, man. Her skin was the same way. Oh.
Yeah, that just happens, unfortunately, sometimes. But again, that was a concern related to quality of care. But officially, though, that was a concern, and so they cited us with that in the end. At next page, F686, also low scope and severity. This refers to the potential for a residents being at risk for pressure ulcers and a failure to ensure the dietary recommendations were implemented. So some residents that were supposed to have received like maybe a certain sandwich or a certain protein milk or a certain supplementation, they cited in this case 2 out of 4 residents that did not have every single thing on the tray that they should have. So that was an oversight in this case. So we were cited as such for F686 in this case. On page 21, F690, that has to do with, that was also low scope and severity. Bowel and bladder incontinence. So long story short, that one, I'll jump to that page here. Oh, okay, yeah, that was the resident who, when they were put to bed, they have a catheter. And so when they were put to bed, the resident had, excuse me, was not wearing a protective leg bag or a privacy bag for the use of his catheter in bed in this case. And so that was cited for 1 resident out of 2 that they looked at. So just noting that as well. On the next page, 23, F697 for pain management. So I will tell the committee that of all the tags that were cited, all were low level except for 1. And that's this one. On page 23, F697 for pain management. This one, if you'll notice on the scope and severity scale, this jumps up 1 level to G. This is what's called a G level violation. So this is taken a little bit more seriously just because of the nature of the concern. Long story short, and actually as they wrote it, the facility failed to ensure a resident's pain regimen was adequate to relieve her pain. This was a resident that was passing. And so certain medication was ordered from the pharmacy, but it didn't arrive quickly enough. And so they viewed that as a concern. They cited us as such in this case. So it is possible because that's now, because of the scope, or well, not so much the scope, but the severity of that issue, it is because it's also a state violation as well, because there's always state regulations that go with federal. It is possible we could receive a fine for that one, of which amount I'm not sure yet because they haven't got that far yet. It could be, just to kind of give the committee an idea, it could be maybe a couple $1,000s in this case, just because of that concern that was cited. So just noting that particular one out of all of them, just because of the concern that they felt with that particular deficiency. That was F697 as far as pain management. F803, this one had to do with, that was also low scope and severity. As I said, they all were except for the one. The facility failed in this case to follow the posted menu for residents on a pureed diet. So the resident that was was supposed to receive a pureed bread source did not receive it. So that was a more minimal item in this case. We were cited as such. F812, these are more dietary related tags. Is an F, which is low severity, but it's more of a, they viewed it as more of a widespread issue. This had to do with the dietary manager having washed her hands and then pulled out a pair of gloves, but did not put them on her hand prior to her grabbing the handle of a utensil, which the healthcare services group that oversees our dietary department, the corporate representative that was here with them said that's not, we're going to submit what's called an informal dispute resolution for that one because there is no regulation saying that you have to put on your gloves before grabbing the handle of a utensil. So again, it was a low scope and severity issue, but he felt that it was not inappropriately cited. So just to note that in this case. On page 33, required in-servicing. So this has to do not with our own staff in this case, but it has to do with agency staff that come in from agencies. There is a certain difficulty with trying to get agency staff, CNAs and nurses trained because they're not one of our own staff. So coming up with a plan of correction to address how we're going to train staff that come in at any given time from any agency that we make use of, and making sure we have documentation showing that they've been trained on our policies. So, but I know of what other facilities have done to address that, so I'm submitting that to the Director of Nursing to submit for our plan of correction. That was it. Those were the deficiencies that were cited as far as our annual health survey. So again, all of them were low scope and severity except for the one in this case.
I got some follow-up questions.
Yes, sir.
What's, oh, this is something else. So G, we might get a fine,
That's correct.
but F,
That just means it's a low severity issue, but it's more of a widespread. So issues are either isolated, patterned, or widespread, but it's still a low severity. So there's no fine associated with anything like that.
well, thank the Lord that we didn't have any J's or K's or L's or A's.
Well, that's an area that I don't want to ever get into
Yeah, I
because that's
know.
called an immediate jeopardy violation, and that those come with more serious repercussions.
Yeah, I'm glad to see that we, overall, I think we had a great survey, don't you think so?
I do, in that, again, these were all, and as I noted too, a lot of these were one resident out of a sample of like a dozen. So they really nitpicked, in my opinion, as far as the things that they cited. Even the issue in the kitchen, as far as the resident not getting a pureed dinner bowl, not, there's the dietary manager not, putting on their gloves prior to touching the handle of a utensil. I mean, just things like that.
Now, a lot of these tags, you just gotta do a correction action report by a certain time frame,
We have
correct?
10 days.
10 days.
And normally it would be called what's usually called a desk review, where we submit documentation and then they, review it from a distance. However, because of the one tag that was at a harm level, they will more than likely have to come in to do a revisit, which all that is we put together a binder showing all the deficiencies that were cited, all the education that was completed, all the plans of correction that we put into place. And then they basically come, they sit in the conference room, they look it all over, and then they sign it off. That's basically what that comes down to. So as far as that practice in this case. So that's what will be expected more than likely in this case, as far as a revisit. So.
Yeah, that's all I have then, thank you.
Okay. Okay.
Sir.
Also, and just to note these as well, there were, we always have 2 surveys each year. This is the state. That's the state. You guys should have gotten a copy of the life safety survey. Yeah, those are the state. Just the state regulations just go with the federal, so we're cited in the same way for certain tags.
You mean this, the 10 pages here?
Probably not that one.
Oh,
I
okay.
thought I had it, but maybe I didn't. But actually, I had already emailed out as far as the concerns that they were going to cite. There were,
The one sheet.
yeah.
A whole
Hold that up
bunch
here.
sheet. Anybody have?
It was on the agenda
In the
link.
agenda packet link.
Yeah, I think I pulled everything up.
It was within the report of Marcos's, so.
Okay.
So, and there were 4. As far as actual life safety, fire safety, electrical safety, that kind of thing, there were 4 that were cited. There was a concern of an exit door in the facility's Alzheimer's and dementia care area and I never would have assumed this just going into a new facility. I wouldn't assume this was the case, but if you're on that hall and there's a fire and you have to run out like towards the main building, as far as by the nurse's station, you have to pull open the door. Whereas the normal expectation is that on any emergency door, you just push out. So I obviously wasn't with the county in the 1980s, and I don't know why it was constructed that way, but we might just have to change the way that door opens in this case. So a fire exit sign not being present where one should have been. It looks like this is on the Oakwood area on the north part of the building. It looks like up above in the area of the nurse's station. Looks like there's like a kind of a junction box that used to be there, but they covered it up and painted it. So I think Seth is going to just use that wiring that's in there and put it in where it's supposed to be. Put the emergency sign up, and then we'll just take a picture of it just to show that that was corrected. There was, so life safety also includes, again, like, use of power strips. There was a power strip in an office that was used incorrectly. And I've seen life safety surveyors do this before. In an office area, you can't have like if you have an office refrigerator, you can't have it plugged into the same power strip as like everything else. So, or a microwave for that matter. So that was the concern with that. And then the concern of the facility having a mechanical room, which allegedly the sprinkler had, So, and actually as a result, and I'll include this as far as the HVAC work as well. In the north part of the building where Lester's has been working, some of the new duct work, it actually kind of blocked a fire sprinkler. So they're just making an adjustment to that to bring it so it's covered on both sides. That's basically what that was. And actually, and just a note with that as well, the HVAC work on the north end of the building, as far as the originally contracted work, is done at this point. During the course of that work, however, Seth has informed me that there were certain air holes that were found in some of the original ductwork on the north area where they were working as far as the air handling systems there, which is outside the scope of the original approved work. So Seth is in the process of getting me as far as whatever they're going to submit as far as just to take care of those air holes in this case. But the temperature, and because I've been walking down there just kind of surveying on my own, the temperature that's being held in the Birchwood North area dining rooms is holding at like 70, 71 degrees. So that's been a very good thing, because those dining rooms with the director of nursing has told me with them being big and open as they've always been, it's hard to keep a room heated with large windows and kind of the wood facade just being kind of weak a little bit. So that's been better. So the Birchwood area, as far as I'm concerned, without them even taking care of the air holes in there, I mean, I can use it at this point. We've been serving residents down in the north part of the building in that dining room. And as far as even just habitating those two hallways on the north end there, the Birchwood areas. On the other side is the Oakwood area, kind of the interior side of that part of the building. We've already got residents living down there anyway. Oh, which takes me, Mr. Haddad, to your original question. So just so that there's no question, I can hopefully say this, and hopefully it's understood by all. When the scope of this work that was agreed to, as far as the HVAC work, as far as the air handling work that was agreed to be done this year in this case, when it was started, it was communicated that when they start that work, that basically our ability to keep the north part of the Birchwood, let me speak specifically, the Birchwood part of the building heated appropriately would not be a possibility because of the work that they had to do. So when that work started, I knew that the south part of the building was going to be affected in the same way when they started that work, which is now also started as well. They've started the south portion of the building work now as well, as far as air handling system on the south end, the redwood area in this case. So knowing all of that was going to be done, I made the decision in December to relocate residents to the inner parts of the building. So not the furthest northern end, because I knew they were already going to be working there. So we used the Oakwood area, which is right inside, which is one long hall. The nurse's station, a short hall, and then a long hall. Because that's on the inside, we could still heat appropriately in there. That was a habitable area. So I moved residents into the Oakwood. Those residents used to live on the south end of the building, but since I knew that work was going to be commencing as well, I moved those residents into the habitable areas, so that whenever Lushers was going to start the work on the extreme north ends or south ends, they could hopefully just get in and get it done. Because I didn't really know that the actual time frame it would take to get the project done, but we only had, upwards towards in the 40s anyway. It's not like the entire building was full. So just in the interest of trying to make sure that the project could get done as quickly as possible once they came in and got it started, I just went ahead and used the habitable areas that we had. So as far as Redwood, the Willows, Alzheimer's and dementia care area, and then the Oakwood area. And it proceeded that way. So in terms of being bedlocked, not necessarily. We have beds open right now in the Redwood area. They're working on the south area now. So that's not a habitable area right now because of our heating issues with them doing that work on the south end. But now that the northern end is now, in my view, mostly finished, I can start utilizing those areas for occupation. And that's probably a 50 to 60 bed area. So yeah, we on the northern end, now that work is essentially completed, I can start using those beds for occupation.
Let me ask you something. So this was a $200,000 project that we okayed here a while back. It seems like this project's been taking a long time, drawn out. Do we know when this is all going to be finished?
Well, this project started in November, December at this point.
Well, it should have started way earlier, but
I was gonna say, I mean,
Yeah.
the funds for this particular project were agreed to even prior to me coming on board.
Yeah, correct.
Going into the previous last fiscal year. So and again, just coming on board new, I didn't really know what to expect in terms of the actual time frame until they actually got started. And so once they did, I mean, there were complications that came up as far as equipment that they needed and such, which I just think this committee knows because I've given a report each month, just noting the fact that the work was proceeding, and it has been the entire time. So there's been, no change to that as far as what that's been. They just have had complications in their work that they set out to do, which lengthened the project a little bit longer than I would have wanted it to. But now that they're coming to an end as far as the work on the northern end, they'll hopefully, I think they've learned from that experience as far as that part of the building, which hopefully should make the south work go a lot faster. So hopefully
So
we'll
they
have,
still gotta go down and do the south. end.
which they've already started this week.
Okay.
Yeah.
So we looking at maybe 30 days,
Possibly.
60 days?
I will see if I can confirm from them again, like I said, with the work that they've done on the north end of the building. Hopefully we'll help them to know how to work faster on the south end.
Mhm.
Now they see what's involved in the building.
Okay. I wanted to go back on this life safety thing real quick. What did we, I finally found it here. On these life safety things, they have to be corrected by so many days.
The same as the health. So I have 10 days to write up all these plans of corrections, do all the training, submit all the evidence, and then they will come in and do a revisit for the health side. The life safety should just be a desk review because there were no serious tags with those.
Okay, then. Okay, thank you.
From a regulatory standpoint, again, that's pretty much what I've got on that as far as that goes. Bring up my original report here. And as far as from a social service, as far as from a departmental review, as far as that, I have nothing further either. So as a whole, I think that's everything that I had as far as my report for this month.
Okay, that was a lot.
Thank
Thank you.
Real quick, what was this 10-page thing that we got?
Those, so for certain tags that are tagged, like I said, the one tag that was tagged at a certain level of harm would also then cross over to the state side. That all that means is they mirror each other.
Okay.
The fines actually, when a facility gets a fine, a true fine, that's not actually given to you from the state or from the federal level. That's given to you from the state level. They send those out.
But sometimes the feds follow up also with a fine too.
Oh, well, the federal government does their own processes because they kind of oversee what the state does in terms of public health practices. But yeah, so they kind of work together in that way.
Okay, thank you.
Chairman?
So I have several questions if I could. One, do you know how many residents we could currently accept at the facility with the current staffing levels? I know we're at 43 today.
We're at 43 today, going as we've already approached 50. At this point, we're using pretty heavy usage of contracted staff. So continuing that pattern and requesting the use of more contracted staff, there's really no limit right now because no estimated limit, just because we would have to make use of greater amounts of staff than we would pull in from agencies at this point. So as far as the bed availability that we have in the building, we still have more beds to fill. On the 24-bed dementia unit, we have 7 back there right now, which most of those are long-term people. The Redwood area, which is where we put most of the short-term people, we have some bed availability, a few bed openings there. And then the rest of it's long-term. With the like I said about the northern Birchwood end of the buildings, those are now habitable areas. So, I mean, that's another 50, 60 beds down there. So, there is no limit, at this point.
And all those beds are certified.
All the beds in the entire facility are duly certified for Medicare and Medicaid.
Do you believe in your experience that our private pay rate is too high to be competitive?
As it is, yes. It is very high. It is higher than, and of course, I think we might have discussed this previously, I don't remember, but just that being a county home and the rate of reimbursement we receive as a county home, and you and I have talked about this as far as if you want to offer any additional commentary on that.
Well, there's reports out there too that tells you what.
The other county homes
Yeah,
in Illinois.
yes.
But to answer your question, yes, I do feel that it is very high. Compared.
So we were told previously by the management company that we needed to increase the reimbursement rate, I believe, for Medicare or Medicaid. Is that still your thought that we continue down that same path?
So there is a cost report that is completed by skilled nursing facilities that receive Medicare and Medicaid each year. And there's a lot of factors that go into that. I would have to take a look at what we're looking at now for this year to be able to give a better estimation on that. But I would like to look at that though. Since you did bring it up, I would like to look at that and see if there's any potential for adjustment.
Okay, great. Balance sheet, income statement, cash flow analysis. I don't think we've ever seen a balance sheet, but I would like to start seeing a balance sheet that shows the assets and the liabilities. I believe that some of the assets that we have that the billing company is working on probably are not performing assets any longer. They probably need to be written off, and I'm perfectly fine waiting until they do a complete look back to see what they believe is collectible and what's not. Is that something that can be put together, a balance sheet, the income statement? And all I would be looking for would be quarterly. So say the April meeting, we would have a first quarter balance sheet, profit, loss, and cash flow analysis.
So, and I was discussing with the county administrator. So this company, their focus is, I would even say solely on billing and collections.
Mm-hmm.
So, because the primary need was to make sure that we were able to bill correctly so we can continue to sustain ourselves, collecting on all accounts, every payer source that we had. So that revenue would keep coming in to the best of our ability. And I think that they'll be able to do a very good job at that, as far as any accounts outstanding. But that is their sole focus. So from an operational standpoint, as far as like a profit and loss statement, that's not really their area of focus. And now that's not to suggest that couldn't be compiled, that data couldn't be compiled. We can take examples from what we've maybe received from the previous provider in the past and try to put that together maybe going forward as a facility, maybe each month. So we can maybe provide comparable information.
Okay. Yeah, our biggest issue, and this goes back 5-6 years, is cash flow. We're going to have a heating and air conditioning bill coming, a large one. We have payroll that we're just barely making. We have IMRF. We have workman's comp. We have vendors that want to get paid, and there simply is not enough cash to go around. We did an advance on the expected real estate levy to pay TCM what they're owed. I have, as I've said for years, have strong concerns about how we're going to pay all these bills that are going to come. There's no more money to be had. We've already mostly used up what the advance on the levy was going to be, or what's allowed to pay TCM. What are your thoughts about cash flowing this?
I was to say, for what it's worth, Mr. Chairman, those thoughts have been in my head as of late. Getting the reports from the county treasurer as to, as you said, cash flow. At the end of the day, cash flow. In the short term, what I'd like to see is, and again, obviously not trying to compare apples to oranges or apples to apples, but with the current provider, as far as their collection efforts and the level of detail orientedness they would have, in that way, to see if those new collection efforts would bear new fruit in terms of everything that we can possibly collect that we are collecting. And they've even said during their initial presentation, what percentage are we actually collecting each month to make sure that we're getting everything that is due to the facility. And once I can see that, even after a month or two, maybe, we'll say that I can say, well, this is kind of where we're at this point. Census is an issue to begin with, which we're obviously continuing to work on that. The census fixes most things. If our census was in the 50s or 60s or higher, obviously that would change a lot of things. But in the meantime, I think our first, my first intention would be to make sure, first of all, that we're getting everything to do to the facility as far as regular, active collection efforts, and then just look at what that is. And again, even in the whole time I've been on board, I wanted to speak with the county treasurer as to what are we looking at? I'm looking at average daily, not average daily, but average census on a monthly basis. Compare that with what kind of revenue have we actually been bringing into the facility each month, which even the county treasurer could provide to me as far as what we've deposited, each month, regardless of when it's coming in, but as it's coming in, just doing a direct comparison as far as what that's been and what it could be. So, and then once I can see that, then I can make a more specific projection as far as, where we're at this point and what other suggestions I might make. So I just want to see what they can do as far as,
Sure.
that level of collection efforts.
I would also like to see quarterly, through the beginning of each quarter, a budget. What did we used to call that? Basically a budget status report.
Okay.
To where we are to the budget. I don't think it's necessary to do it monthly, but it would be nice to see where we're tracking.
I am going to put an increased focus on the department heads, maybe in ways maybe they haven't had more recently. As far as cost reduction, staffing is obviously the biggest cost, as related to personnel. So I'm going to be working with the director of nursing to make whatever cuts we can make in that way as well, to try to reduce, obviously expenses as a whole for the facility. When I worked in Fulton County, we did look at that every month, as far as just a budgetary breakdown, line item budgets, as far as where we stood from month to month. The county treasurer would provide that for us, and then we could just look at that. She would also give us a breakdown of again just what we've been receiving as far as revenues. So that the nursing home committee could see that each month as far as what is actually coming in, from month to month, as compared to what our actual expenses are. And I can't speak to the previous provider, but I'd like to take maybe kind of a fresh look at that now and kind of see, what is literally our expense, our expenses compared to what we're actually bringing into the facility each month, on average at least. So.
Can I keep going?
Sure.
I only have a few more, I promise. Any positive turn on VA?
Yes, I thought that question would be asked. As to conversations that we had with the previous provider, I basically taken that on myself, and I've put a contact out to the lady that the previous consultant and I were working with as far as a VA contract, and I'm trying to push that process along. So by next month at this point, I'll have a more solid update for the committee as it relates to that. I intend to get an agreement secured with the VA so that we can have what we used to have, and to be able to admit residents in that way.
And then the last thing I have, I guess it's more of a statement, but maybe you can tell me if I'm correct in this or not. I know TCM had previously told us, and they had given a date of when any fines through the state of Illinois would be automatically waived. I don't know if that was through 2025, maybe 2026.
Staffing violation.
Maybe that's what it
Was it
was.
staffing?
We have not received, and I'm familiar with those, the quarterly staffing violations. We haven't been cited for anything as far as
Sure.
and related to that, but let me confirm on that point.
Well,
I
and
think
that
it
may
had to
have
do
just
with
been
the
for
PBJ.
staffing. Pardon?
I think it had to do with PBJ staffing violations.
Oh,
or no
because we submit
monetary.
PBJ and then they kick back amounts to be paid because we didn't meet staffing requirements, basically.
And I didn't know if that translated to other findings or not. I
No,
guess-
that's kind of, I would call that kind of the state's own program.
Okay.
I mean, it's public health, but it's kind of the state's own thing. It's the governor's thing too, in a way.
Sure.
But I will confirm on that.
Great. Thank you. Thank you for giving me that opportunity to ask those questions.
I want to follow up, Mr. Helms, Chairman Helms brought up, on, do you need any kind of letters of support from any of our veterans organizations?
That may become necessary. I mean, I don't think that would necessarily be a bad thing. I haven't gotten to that point in our discussions with the, excuse me, with the VA representative that we've worked with so far.
Will you be willing to come and speak to our monthly VA, I mean, not VA, but our VFW and American Legions and AMVETS? The city manager is the vice chair of the AMVETS now, and we could recommend you to come and speak. This would help benefit getting veterans out to the nursing home.
I have no issue with that.
I'll talk to the person that's in charge, get a date to see if to have you come in and speak. And at that time, maybe we could talk about letters of support too,
Okay. I will keep the committee updated as to the need in that way. And if that would become a benefit in that effort, and we'll go from there. But I will plan for now the March meeting to give a more comprehensive update as to any potential VA agreement.
All right. Any more questions from Marcos and Jennifer? Okay. 7.2 is matrix care report. I think you've went into the.
Oh, sorry. I guess I got ahead of myself.
So moving on to 8.0 old business, new business, 9.0 new business, no new business, 10.0 public comment. Anybody? Seeing none? All right. Moving on to 11, executive session. So executive session,
You don't have to
we'll
say.
start that all over again. 5 ILCS 120-2C, employment matter in the appointment, compensation, discipline, performance, or dismissal of specific staff. Do I have a motion to go into executive session?
So moved. Second.
By Mr. Hadley, any discussion? All right, so we'll need a roll call to go into executive session. No,
Roll call, come on.
come on, all right. All in favor, say aye.
Aye.
Opposed? All right, so we're gonna go into executive session.
You need to step out.
Will you allow us to stay? I was gonna say, you can, I was gonna say, they can stay.